Thank you so much. I'm presenting a data on a population-based study for surgically managed patients, and I'm presenting on behalf of Ali, who is a master's student who worked on this project. Thank you. I worked on this project. This is a collaborative work between a group of dermatologists at Women's College Hospital and Dalalana School of Public Health. And here are my conflict of interest. Basically, to evaluate the objective of the project was to evaluate the economic burden of HS using a comprehensive population-based data set and showing is there any factor that is associated with higher cost in patients with HS. Why this study is interesting, after the talk by Dr. Gorg, maybe not very much interesting because you have such a huge database of 50,000 patients with HS. But one reason is the healthcare is managed and funded provincially in Canada. Therefore, the total and sectorial costs are traceable. Second, considering the multi-ethnical distribution of particularly Ontario, the result of this study, and because of the diversity, could be reproducible to other ethnicities. And it's one of the large database set on HS. And what made this study possible is that Institute for Clinical Evaluative Science in Ontario, that is based in Sunnybrook Hospital, they have access to all health administrative data and health survey. And based on under OHIP Act, the researchers in this center are allowed to link the encoded population-based health database for conducting research with keeping the confidentiality of patients. And the research was approved by U of T Ethics Review Board. In this study, we used, the limitations are, we used ICD codes, the same as many other studies that we are using ICD codes. It has their limitation, and we used ICD-10 codes. And plus the OHIP billing code that we used are surgical codes. We used 2 surgical codes, then assumption is then when a patient has surgery, then should have a more severe disease. Then we need future studies to look at evaluation, the total burden, then this might represent more severe cases. And because of logistically, we couldn't use the propensity matched control model that commonly used in cost analysis. What we did in this, we built a cohort of, the Ontario cohort of surgically resected HS or OCSR-HS. We look at the data for 10 years, 2002 to 2013 in Ontario database. We used the 2 surgical codes, RO59 and RO60, which means RO59 is a resection of skin and sweat gland, axilla, groin, perineal area for HS or hyperhidrosis. RO60 means the same surgery with using flap and or graft. And we used the ICD-10 codes for comorbidities. We used the Johns Hopkins aggregated diagnosis codes. In total, we had 6,803 patients with HS that went under surgery in 10 years in Ontario. We excluded patients that, based on diagnostic code, they had hyperhidrosis. Then we ended with 6,244 cases. The total annual cost for HS were calculated by adding costs per sectors from 10 years prior to the index date, which is surgery, and 10 years after index date, and with, for both cases and control group. And the difference between the total and sectorial cost in cases and the match control was estimated as attributable cost of HS on healthcare system. Overall, with 6,000 cases and 18,000 age and sex matched control, We had 65.5% female patients. Female to male ratio was 3:1, similar to the data that you had here. But in older age, above 65, we had 1:1 ratio, male and female. That it's interesting that probably it shows that male patients with HS have longer duration of the disease. Less than age 30, 25% of our patients, 30 to 60, we had 4,000 patients, 66%, very similar to the data that you had in your database. And the number of physician visits, emergency, hospitalization, dialysis, it was much higher in HS group compared to control group, like 10 physician visit more than control in HS group compared to control group. I put this one, I said this should be a dermatologist visit. If we look at the index day surgery before and after, in patients per person, 2,649 Canadian dollar was the cost in 10 years prior surgery, that was increasing, and 10 years after surgery was 1,800. While in control group was 918 prior surgery and 1,596 after surgery, that the difference was significant. In the period of 10 years leading to surgery, the average cost for patients was 1,731, higher than matched control. That was significant. And also in 10 years after surgery, this difference even increased to 2,856. But remember that we have older patients now, and was again significant in compared to matched control. HS cost was higher in the year of index. That was because of the surgery that they had. And the cost of HS was gradually increased in the years prior to surgery. And here you see in female patient, the peak that you see is when they had the year of the index year, the surgery, and the cost after surgery also stayed high. And compared to control group, and here for male patients compared to control group. And interestingly, that average cost of HS 10 years prior surgery and after surgery both was higher in male patients. For the whole period and follow-up, average total cost was 4,230 for men and 3,000 for female patients. And as you see here, both male and female, the difference. Then HS has a huge burden with high resource utilization using a comprehensive population-based data set. And the cost of HS is higher in male patients with HS that could be related to high severity or more longevity of the disease, longer duration of the disease.